the venous distribution, three sets of veins, superficial, deep and perforating. Superficial lie in the superficial fascia, great and small saphenous vein. Okay? Now deep, surrounded and supported by muscles accompanying arteries, including tibial, peroneal, popliteal and femoral, and below knee arranged as a pair of vena comitants along arteries but above single vein. Perforating communicate superficial with the deep veins through deep fascia with valves at the ends permitting blood flow from superficial to deep, not in reverse direction. This component, this slide, I want to say, if you know this part, then you will know the total, the system, how it is working, how the perforators are working, how the valves are working. Now this is a foundation of this lecture. Now see, I repeat, the three sets of veins are superficial, deep and perforating. Superficial lie in the superficial fascia, great and small saphenous vein. When you go to the hostel, you see your own saphenous vein, the root, and then deep, surrounded and supported by muscles accompanying arteries and include tibial, peroneal, popliteal and femoral, and below the knee arranges at a pair of vena comitants along arteries but above single vein. Perforating communicates superficial with the deep veins through deep fascia with valves at the ends permitting blood flow from superficial to deep, not in the reverse direction. Now, venous distribution, all veins have valves directing blood to the heart, valves more in deep veins except in soleus, arranged as venous sinuses, blood flow slow when soleus is at rest. Now the soleus is a muscle in the leg. Now prolonged rest in bed, deep vein thrombosis, complication of pulmonary embolism. Now this is a very common condition. When patients are in ICU or operation, prolonged operation, kichu bolbe? Oh, bosho. Sit down, sit down. একটা কথা আছে, বাংলা বোঝো? যদি হয় সুজন, তেঁতুল পাতায় 9 জন। মানে 9 leaflets are there in the tamarind leaf. So if you are friends or sujan, then 9 people can accommodate yourself. Okay? Now, what you have to do is that after this type of patient are in the ward, sent to the ward, you after anesthesia, spinal anesthesia, for it stays for 2 hours or 2.5 hours or 3 hours maximum. Now the attendant, it can be the nursing staff or it can be the relative attending. You tell them to just massage the lower limbs and you to just bend and massage. You tell them to turn aside and you just show that you just massage. So the circulation is not stagnated. And now the previous slide, when I was telling the stagnation, now what happened? Most of the big hospitals throughout the globe, there is means you get a good challenging operation done, your patient comes home, but there are with some small bed sores. So bed sores is a outcome of the prolonged sleeping without any movement of anything, or he or she is unconscious. So it is you make it a practice when you are in your clinical rounds. Operation part of we make it a routine. It will come, okay. Now, longest vein of the body, great and long saphenous vein. Longest vein of the body begins as a continuation of medial end of dorsal venous arch, 2.5 centimeters in front of the tibial malleolus, ascends behind the medial border of the tibia to reach knee along medial border of the thigh, passing through the fossa, ovalis, saphenous opening in femoral vein after piercing the femoral sheath, 10 to 20 valves. Okay. Now, if you tie a tourniquet, you will see this thing, but you can feel it, you can see it. Okay. Now, it can be a short note. Now, tributaries of the great saphenous vein, below knee, posterior arch vein, anterior leg vein, few veins from the calf communicate with the small saphenous vein. In the thigh, anterolateral vein, posteromedial vein, before piercing cribriform fascia, the superficial epigastric, superficial circumflex iliac, superficial external pudendal veins. Deep to saphenous opening, deep external pudendal vein. See, this is the femoral vein. This is the popliteal. Popliteal vein is here. And small saphenous vein. Now, this is just before the opening of the cribriform fascia, the femoral triangle and the inguinal region. When you dissect the lower limb, you will be seeing, and these are the perforators. Now, valves of the great saphenous vein, 10 to 20 valves, 2 constant just before it pierces cribriform fascia, others at junction with femoral vein. So you know this part, 10 to 20 valves, but 2 constant just before it pierces the cribriform fascia, others at junction with femoral vein. Saphenofemoral vein. In 80% cases, external iliac vein presents a valve which protects saphenofemoral junction against high pressure, while rest 20% do not have valve, become varicose, commencing from this junction going downwards. Now, 80% is external iliac vein presents a valve, but the rest, the junction high pressure, spinofemoral junction against high pressure, while rest 20% do not have valves, become varicose, commencing from this junction going downwards. Now, the varicose veins is a complication for people who are working in the army, in the police station, even nursing staff, even your doctors. Okay, long time you are standing, working, or this thing, then there is a varicosity. Okay. Now, venous drainage. This is the brachiocephalic vein, subclavian vein, and axillary vein. This is the azygos vein, lateral thoracic vein, and from here the hemiazygos veins. This is the diaphragm, and this is the thoracic cavity, this is the abdominal cavity. Now, external iliac vein, the inferior epigastric vein, superficial epigastric vein, inguinal ligament, and femoral vein, and great saphenous vein. Now, inferior rectal vein. Now, when you are now from thorax, you will be doing your lower limb and then go to the abdomen. So, now saphenous opening. You can see the saphenous opening here. This is the femoral sheath, and this is the genitofemoral nerve. The femoral branch, there are 2 lymph nodes, long saphenous vein. Now, when you dissect the femoral triangle, you will see this picture. Okay? Now, saphenous opening can be a short note. Okay. The whole lecture, if you go through, when you read your text, you will see there will be breakup of small question, short question, or in Viva they will ask you. So these are important landmarks. Now this is a picture from my one of my favorite books, Grant's Anatomy, and see saphenous opening, great saphenous vein joining the femoral vein within the femoral sheath, lymph nodes, and the attachment of Scarpa's fascia, the Scarpa's fascia, and see the femoral sheath and the lymph nodes, great saphenous vein, the fascia lata, and attachment of Scarpa's fascia, superficial inguinal ring, the intracranial fibers, and this is the inguinal lymph nodes. Actually, I like this type of illustrations, and I've incorporated, because in your new books you won't be seeing them. It's a beautiful book. It's out of print. Now, a small saphenous vein as continuation of lateral venous arch below and behind the lateral malleolus. Yes. Ascending medial to the pseudal nerve and lateral to the Achilles tendon. The Achilles tendon here. Posterior, this is the posterior picture. Subfacial course between the two heads of gastrocnemius. This is the two heads of gastrocnemius. And posterior femoral cutaneous nerve accompanies the upper part of the vein. Now terminates by joining great saphenous vein in the upper part of the thigh, bifurcate, one joining great saphenous vein, other ending in popliteal or deep vein. This is the popliteal vein. Now, it ends in great saphenous or deep venous of the veins of the leg, has 7 to 13 valves. So this has 10 to 20 great saphenous, and the small saphenous vein has 7 to 13 valves. Now perforating veins, constant in number and has fixed position. Constant in number and has fixed position. Connects tributaries of saphenous vein with deep veins after piercing deep fascia, and provided with valves at each end, thus directing blood flow from superficial to deep veins. Now the perforating veins, constant in numbers and has fixed position, connect tributaries of saphenous vein with deep veins after piercing deep fascia, provided with valves at each end, thus directing blood from superficial to deep veins. Now, position of perforating veins, a mid-hunter perforator, great saphenous with the femoral vein in adductor canal. When you see, you will be dissecting the lower limb, the adductor canal, you will dissect, and this is a capital letter Hunter, a mid-hunter perforator. Now, John Hunter is one of the greatest anatomists of modern medicine, and he is also a school dropout. খুব বাজে ছেলে, বদমাস ছেলে, হ্যাঁ, নেশাখোর. So you will find that picture in the dissection hall at the end. I have to replace that photo in front, I think, because John Hunter is one of my, I have him in my heart, and because he has written 13 volumes of books with illustrations in surgery and in anatomy. So he's a school dropout, but his brother was a established teacher in London, and he used to teach anatomy and other things. So one fine day he wrote a letter to his brother, just please give me a chance to work in your laboratory as an attendant. What Vivek is doing. So he went and joined him because his brother was really happy that my younger brother John is now wished to transform himself. Then he did not look back. So the knee perforator, great saphenous with posterior tibial vein just below knee. 3 medial ankle perforators connect great saphenous vein with the posterior tibial veins close to the medial border of the lower third of the tibia, joined with one another by series of arcades forming posterior arch vein. A lateral ankle perforator connects short saphenous with peroneal vein at junction of middle and lower third of the leg. Now this is the position of perforators. See, this is in centimeters. Now the level of first medial perforator at this level. You try to draw a sketch when you go home and you mark as I'm showing you. Now, see, this is the posterior arch vein, This is the great saphenous vein here. Now see the foot is being drained. Level of first perforator is this level. And level of second medial perforator at 13.5 centimeters and level of third medial perforator 18.5 centimeters and posterior arch vein, and this is the great saphenous vein. Now you see the mid thigh Hunterian perforator insufficiency, this competent dot perforating vein and buoyant perforating insufficiency. Now this can be a short note, or they can be a MCQ naming Hunter's the Hunterian perforator insufficiency. Dodds is also a anatomist, perforating vein, buoyant, actually perforating insufficiency. So you can see the level. See, you just draw 0 to 40 centimeters, just 5 centimeters apart, and you label them and you get position of the perforators. Okay. Now clinical. Now sustained over distension of superficial veins leading to short dilated venous segments. See, this is a short, this is again this see dilated here. Now cause of varicosity might be due to venous valve failure either in proximal end of the long saphenous vein or failure in perforating veins passing from superficial system to high pressure deep veins. Now there are two causes of varicosity. One is the sustained over distension of superficial veins lead to short dilated vein segments. Cause of varicosity might be due to venous valve failure either in proximal end of the long saphenous vein or in perforating veins passing from superficial system to high pressure deep veins. Now, there is a leakage of red blood cells due to thin walls of vein breakdown cells and hemocentrin deposition. Venous stasis leads to edema, prone to injury and ulceration. Sluggish blood flow lead to venous thrombosis and embolism. Coronary artery bypass operation. Now the venous this long saphenous vein as taken as a graft to bypass surgery. As a graft, they harvest the vein, portion of the vein, and they graft it in the heart. Now, superficial inguinal lymph nodes, upper group chain beneath inguinal ligament. Lateral group receives afferent from gluteal region and anti-abdominal wall below umbilicus. Medial group from subcutaneous tissue below umbilical, external genitalia, perineum and lower part of the anal canal. Lateral vertical group along lateral side of great saphenous vein receives afferents from superficial lymph vessels of the lower limb. Now, any person with the inguinal lymph nodes enlarged, so it can be, in this part I am trying to stress, the medial group from subcutaneous tissue below umbilicus, external genitalia, perineum and lower part of the anal canal. There might be some infection or something. And then the lymphatic drains and the your policeman, the lymph nodes. So they get enlarged, or there can be lymphadenopathy, non-specific. You cannot specify that this is the this disease is there, but you can if there is multiple, then you can take a lymph node FNAC. If it is not even your diagnosis is not confirmed, or if there is some what you are thinking is not matching with the diagnosis, then go for a excision biopsy of a simple lymph node. But not any small boy comes up and says, দেখুন আমার এখানে সব গুটি গুটি দাঁড়িয়ে গেছে, এখানে গুটি গুটি দাঁড়িয়ে গেছে. So you have to clinically, you might be having some impetigo or some abscess in the lower limb. Then there is a lymph drainage, there is the lymph nodes get swollen up. Even see a baby with scalp, some impetigo or some infection in the scalp, or some abscess in the posterior aspect of the ear or in the submandibular region or something, then the lymph nodes in this area get swollen up. So, now superficial inguinal lymph nodes, vessels following small saphenous drain into the popliteal nodes, afferents from superficial group drain into external iliac nodes. Some of the vessels cross over femoral canal intercepted by deep inguinal nodes, and some in front of lateral to femoral vessels. One of the three in number, deep inguinal lymph nodes, lie on the medial side of the femoral vein, here, and junction of great saphenous and femoral vein, middle in the femoral canal, highest in the lateral part of the femoral ring, and efferents drain into the external iliac lymph nodes. Now, when you dissect the abdomen and the anterior part of the thigh, the femoral triangle, then you will be seeing the lymph nodes. Now, position of lymph nodes, see the deep inguinal lymph nodes here. The popliteal group of lymph nodes, see the green. Now, applied involvement of upper group, infection or malignant growth, infraumbilical part of the abdominal wall, gluteal and perineal region, external genitalia, anal canal below pectinate line. Involvement of lower group, enlarged in diseases affecting the lower limb. Now, this is a picture. Before operation has been povidone. I operated on this person, and this is we removed total excision of this lymph node, inguinal lymph node, and the testicular tumor. Now, this is filariasis of the penis. It was very common in previous days. But this what I did is that the whole, the penile, the filarial skin, I excised, totally excised, and the thing is that it is interesting, the prepuce, when you read the abdomen penis, then the prepusal skin is not affected by filariasis. So what I did is that, এটা এরকমই ধরো, so this whole skin I removed, the filarial affected. Then what I did, this is the branch penis, and this shaded thing is that the prepusal skin I just turned inside. And then what I did, I took a skin graft and I now, actually my father was just standing, he was not assisting. Then I questioned him. After the operation I finished, the skin graft and everything, this is the picture and this is this thing. Then I asked him, who will be the happiest person in this case? So my father smiled and he said, his wife, because 16 years he didn't go for an intercourse, because you can see the huge skin. It cannot accommodate the vagina. So this was a simple procedure which I performed in my place without training in any plastic surgery hospital. I just read books and books, but in books this particular case was not there, but the skin graft, how you handle, and I did a video. And in the Royal College of Surgeons of the World and Associations of Surgeons of India had a conference in Delhi in 90s. I met Professor Brian Morgan from Mount Vernon Plastic Surgery Hospital in the outskirts of London. I gave him this raw video, and non-professional people, a person doing the video who does marriage photography or something in those days. So, but I gave it. But I questioned. One question I asked him, sir, there's a problem that to get an erection, how you get an erection? Then he told me, you inject, you tie a tourniquet, you tie a tourniquet at the root of the penis like this and inject normal saline, and that is erection. So at least roughly you can gauge and calculate how much skin you should put. It can be little extra, but ultimately it did function properly, and in later phases, at least I have done 10 such type of cases, not a such severe case, but with the filarial this thing, penis, with edema and lymphedema. And this is one thing. And then what happened, Mount Vernon, he took the video, but he lost in transit in his, one of the bags was missing in the airport. Then he went back, but I met, in Singapore, the Journal of Anatomy editor from London had come. I attended his workshop. Then I gave a thing and a letter. I gave it to that editor, and he handed over to Brian Morgan, Professor Brian Morgan, and he, after seeing this, he invited me for 7 years in every summer, but I could not go. So what I want to say is that if your work has a proper, what to say, this thing, your proper result, you can get your place. Anyway, this is female with huge filarial labia and clitoris. Okay, and now even this is one less severe. See, this is a big. Now, after excision, this is the picture. Now, this is one thing what I want to stress. A good MBBS is a good postgraduate. Pore jao. Don't look back. And don't be in depression. You just read. Read and write, scribble. Everything will fall in place. Okay, now, golden facts to remember. Longest vein in the body, great saphenous vein. Most preferred site of venesection, cut down, great saphenous vein in the front of the medial malleolus. Nowadays, you get a Gelco needle or Kit Kat, anywhere you can put in. But previously, what we used to do is that a small pipe with a needle ঠিক না, একটু ছোট্ট needle. Now, what we used to do is that make an incision here with a scalpel. Make an incision under local anesthesia and put like this, and it pull the suture at this end and this end, and through this vein you make a small and put that trocar inside. So it was a long procedure. In emergency, in those days, we used to perform this. We had to perform. And small needle and this thing, that was the first stage of your Kit Kat, modern Kit Kat, and that Gelco needles and all this. Okay. Now, this what I used to do is that tie a tourniquet first, and tourniquet here, and then the vein swells up, and then you make this procedure, cut, just at the side of the vein, make a small incision and then lift up with the needle and catgut, suture and pick it up and make a small nick and put the needle. Okay. Now this is one thing I've just discussed with you. Now, varicose veins, dilated and tortuous vein, commonest cause of swelling in the sublingual inguinal area, enlargement of inguinal lymph nodes. Lymph nodes of Cloquet or Rosemella, deep inguinal lymph nodes present in the femoral canal. Most of the lymph nodes from the lower limb is drained into lower vertical group of superficial inguinal lymph nodes. Elephantiasis. This is what we showed you the previous slide, the elephantiasis or filariasis of the scrotum and also the penis. Now, massive edema of the lower limb to blockage due to lymphatics of the microfilarial parasites. Vein of Leonardo Vinci, posterior arch vein, a tributary of the great Saphenous Vein. Commonest cause of varicosities of veins in lower limb, incompetency of valves in perforating veins or superficial veins or both. Now, my grandfather was a student in Bardwan Medical School, LMF, and my father also graduated as a LMF from Bardwan Medical School, and I graduated MBBS from Bardwan Medical School, Medical College. Now, my grandfather used to say in Bardwan court, there was a Mohodi. Mohodi means who writes the will and all these papers. So they have small table and they used to write. So that person has a big filarial scrotum. So he used to use that as a table.